Good evening, everyone. Thanks, Vipul, Lobo, and KEM and the Pune for inviting me. Adequacy of dialysis. As students, we thought that adequacy means KT over B or urea-based method. So it is a part of it. I'll start with the case, 45-year-old gentleman dialyzing 3 times a week, and it was only 3 hours. Most of the centers, if you ask how many hours you are dialyzing, it's a USA. People are coming from USA. USA is dialyzing 3 hours. Europe is 3.5, 4 hours, and Japan 4.5 to 5 hours also. So we are following USA. So the dialysis also was 3 hours. And he was complaining of weakness, easy fatigability, and dyspnea and exertion. All the symptoms, even the edema, were persisting. He was not able to achieve a dry weight. On examination, his weight was 60. It was height was edema plus. BP was also not controlled. And saturation pre-dialysis was 94. And the hemoglobin also low. So we do dialysis, but whether it is adequate. So we are giving some amount of dialysis to sustain. So urea was 88, creatinine was high, and potassium was also high, bicarbonate was low. So phosphate was also high. And but as virals, hepatitis C. Now most of the centers were getting free dialysis, also getting a more and more HCV positive patients. So I said, the one of the quality is virals has to be taken into consideration. So X-ray was showing as the BP was also high, volume overload, he was having that. So to nutshell, he was getting a properly, with all these parameters, they said he was getting an improper dialysis. Inadequate blood flow was also only, it was on the lower side, but again, you need to say the reduction in the treatment time is also most important, and when you use low dialysate or a blood flow, you may have more and more things. So what earlier we used to say the hemodialysis adequacy is measured by the urea-based methods. So urea reduction ratio or a KT over V. So basically what you see is pre minus post bar divided by pre-burn and 100. So basically you need to reduce urea reduction by around 65%. It's why it came as 65%, we'll come to that, because it showed a mortality benefit when you have more than 65%, then your mortality was less as compared to less than 65%. So the cutoff was taken. So you have adequacy is not only removing the urea, and even the pre-dialysis urea also matters, because if the patient is not taking anything, is 40 or 50 bun, then it is inadequate intake of food. The protein deficiency, you are dialyzing the patient, but he is not nutritionally. So KT over V is K means the clearance of the dialyzer what you are using, and the T is depending on the how much time on machine. Actually, it is not comes to or enters the dialysis room and leaves the dialysis room. It should not be a T, it should be an actual 300 ml of blood flow which you are training, and the distribution volume, which will come to that. So if there is any 65%, you can calculate like 64%, and then it is almost equivalent to 1.2 of KT over V. So if you don't want to calculate a KT over V completely, if you are just doing a URR calculation, if it is 6.65%, then without any ultrafiltration, it comes to around 1.1. And if you do 10% of the body weight reduction, then it will be around 1.3, which all the guidelines says that it should be more than 1.2 or 1.3 is best. But increasing the KT over V more than 1.4 has not shown to be very beneficial in attaining or increasing the reduction in the mortality or any other benefit. So all the guidelines, they said that delivered KT over V should be around 1.2. SPKT over V, equivalent KT over V, only the UK and the SPG, otherwise all are say the SPKT over V. Prescribed KT over V, sometimes you prescribe it, but you may not achieve every time. So your prescribed should be 0.1 more or 0.2 more, so that you can actually achieve a KT over V of 1.2. And similarly, prescribed KT URR should be around 70, and you should achieve urea reduction ratio of around 65%. So when you have to dialyze the patient, first you need to see which dialyzer you are taking. It all depends on what is the actual weight of the patient and how much hour you are going to do it. So you have multiple now, F5, F6, F7, F8. So which all are available, which you need to see the surface area, which madam said. So if you are using an F6, it is 1.3. surface area, and if you're using an F8, it is 1.8. So if it's a huge man, better to use F8. But when you're starting a dialyzer, you're using a 200 ml blood flow and taking F6 or F8, it won't matter. Because you're using only 200 ml, you don't want a disequilibrium. Unnecessarily, you're wasting an F8 dialyzer. Use an F6, then it is better, because you want a lower clearance initially to avoid disequilibrium. So we need to calculate. So this person, 60 kilos, so 60% of the body weight if you take as water, and it comes to 39 ml. And the clearance of the dialyzer, if you see, if you're using to 300 ml, it will be F6, F5 will be 227, and F6 300 clearance will be 243. So you put as 223, you are dialyzing for 3 hours, and then it will become as 39 liters, and the clearance will be 40. So KTVV, what you are getting is 1.05. So it is inadequate, but you are not taking into account what is the ultrafiltration. So ultrafiltration you can calculate by the calculators which are available. If you're using an F6 dialyzer, then the same gets translated into 1.12 KTVV. So at least you can plan initially, and then you need to and you need to calculate the KTOV, then you can adjust it. But if you're starting a dialyzer only, you're choosing F4, and then you're not going to get it. So if there is any same patient, if you use 200 ml blood flow, which initially you start most of the patient with, so you're only giving 0.8 KTOV, which is insufficient. So start with is okay, but on a long run, it is not sufficient. So changing the dialyzer, if you see F5 and F6, it's only 0.02 change in the KTOV. So you are increasing the cost when you use F8 also. You are not achieving. When you're using 200 ml blood flow, F5, F6, both, F8, both all are equal. So F8, if you're using, you are achieving 1.6, and F10, then you may achieve with the same patient, with the same blood flow, because the 259 is the clearance you're going to achieve, because you're having a 300. In this dialyzer, the bigger dialyzer, you need to use 400 ml, then you can achieve a much higher clearance. So you can, if you, the same dialyzer F8, if you use for 4 hours, then you are achieving 1.55 without any ultrafiltration. With ultrafiltration, you can reach much more. So you have multiple calculators which are available. This is one of the HDC, and otherwise UpToDate also has all things which are available. You need to put all your criteria, what you're using it, pre-dialysis, post-dialysis, burn, and height, weight loss. It will give you single pill and double KTVV, and also will give you NPCR also. So NPCR has to be more than 1.2 was better. So the KTVV with ultrafiltration, and I put as a residual renal function as Urea 4, so it will give you treatment of KTVV 1.18, and including the 4, it will give you adjusted for residual renal function, it will give you 1.69, which is reasonably good. So if these patients, if you are dying 2 times a week, then we need to calculate much differently. So if you put at this urea as 0, residual renal function as 0, it will be 1.12. So if your residual renal function is poor, then you need to have a more ultrafiltration, or you need to use for a more duration of time. The time has to be adjustment, or you have to use a higher dialyzer. The randomized trial NCDS has shown that those patients who have 38 versus 26 millimoles in the pre-dialysis, the higher were better. Long duration was much better. So that is the reason we are having a high KTOV, and long duration is much better as compared to low KTOV and short duration. So 1.2 was taken as the KTOV, and the urea reduction ratio of 62 to 67 was taken as a baseline. As the urea reduction reduced, or the KTOV reduced, the mortality was very high. So this is possibly now it has taken as the baseline, but again 1.3 is also a better. If there is any disparity, we are calculating as 1.3, but you are not achieving. You are achieving only 1.1. It possibly because of the low blood flow and the weak vascular access. You are putting a blood flow at 300, but it is, you are seeing a jerky movements in the tubes. So that means that actual blood flow is not 300. It is poorer. And you can put an arterial line and see what is the actual blood flow, which I think tomorrow they will demonstrate in the things. So inadequate dialyzer volume. Dialyzer volume is smaller, or dialysate flow is poor, and the machine is also incorrectly, it is going into the bypass mode intermittently, and ended prematurely, or an excess recirculation is higher. These are all things which you can get a poorer KTOV. If you are very, very happy that you have measured the KTOV has come very high, but it may be disproportionately higher in the actual. It may be you are delivering lower. It may be a pre-dialysis bun was drained by the venous bloodline, so you are collected, your bun is coming very lower, and is a small volume person, then it is be possible. So the diluted sample with the saline, all these are possible when you are getting a very high KTBV, which is not explainable. So how can you increase the dialysis KTBV? We can increase by dialysis duration, bigger dialyzer, blood flow increasing 300 to 400 if your AV fistula gives that much of flow, increase the dialysate flow, US. So time is most important. People have seen that 4 hours, less than 4 hours, it can be done in those who have residual function or preserved function, otherwise lean mass or non-compliant patients, less than 4 hours is disastrous. If there is more than 4 hours, it is good, and thin lean mass patients, but it is very good for those patients who have no residual renal function and high dialysate sodium. So these are all the patients which may be better. And even Japan has shown that the time is most important. Even an NCDS study also shown time is most important. So if you increase same patient of instead of 3 hours, 4 hours, you can give a better KTOV as in even in F5 and even in others. So F6 also you can get 1.49 without any UF. With UF you can get much higher. So shorter dialysis length have been associated with the increased mortality. So those who have more than 4 hours has got as if you compare it to 1, you have a 26% higher mortality when you have less than 4 hours. So time on is most important. It not only clears your toxins, even the phosphate clearance is much better, and even a beta to myoglobin clearance also much better. So if you have more than 2 hours and 210 to 240 and less than, so they have more and more, shorter the duration, they have more and more mortality. So best is to do at least 4 hours. If you can do it 5 hours, it's better. So increasing the blood flow, whether it matters. So if the smaller dialyzer used, then is a blood flow, and even up to F7 you can use 200, and after that if you are 200, your clearance is very, very less. And if you have more than F5 or F6, you can use 300. 400 can be used in F8 and F10 when you can have a better clearance, much higher clearance as compared to the blood flow. So if you're using 300 to 400, then you have to use F8 and F10. So your clearance also much increase, and you're increasing to 400 ml. Use the same dialyzer F8 which are giving 1.39 or 1.4, you can get 1.78. So, but the problem is whether it's actual blood flow you're developing, you need to know. So effect of increasing the dialysate flow. Dialysate flow only can be increased when you are increasing the blood flow. You are keeping the blood flow at 200 and increase the dialysate from 500 to 800, it won't matter. So it's a 200 ml blood flow if it is there. Whatever the dialysate flow you use it is of no use. And if you increase from 500 to 800, there is some increment if it is, you can see beyond 400 ml or 300 ml or 350 ml of blood flow. So clearance will increase, but it is only marginal. Faster dialysate flow, you're removing it. If increasing to 800, you only around 5 to 8% of the efficiency it increases. At least you should have the dialysate flow should be 1.5 to 2 times your blood flow. So you're using 200 ml, though, so it is 400 to 500. Lower than 500, we can't keep it. So if you're using 400 ml of blood flow, then you can use dialysate of 800. Residual renal function is important in achieving KTBV, which I shown. If it is a urea clearance of 4 ml, whatever the dialysate it will be appropriate for the patient, and total KTBV will be more than 1.2. So it has significant effect. Every 1 ml per minute of KRU, it offers 0.13. So if you have a 4 ml, then it will be 0.5 will be increased. So the bun, which is calculated by the urine volume, urea, nitrogen, and the time. So KTBV we can calculate. So increase the urine by diuretic. It may also increase the beta to myoglobin clearance. So in US, the people, even on dialysis, there is thinking that they use diuretics to increase. But when you have reduced the dry weight significantly, they start getting decreased urine output. If you want to maintain, you need to maintain little bit of hydration you need to, or totally drying the patient, your residual renal function also may go down. So this is the chart which shows how residual function, it affects it. So increasing the ultrafiltration, you have seen that if there is only 1 liter of ultrafiltration, if you do it, it will be KT/V1. In the same patient, if you use another liter, 2 liters of ultrafiltration, 0.07 KT/V increases because of the convection. So that is the reason the convection, it will increase the clearance. So if you do much more, then there will be much higher ultrafiltration you see in a KT/V. Now people are having newer machines which gives you automated or online KT/V. It may be urea sensor, or it may be a dialysate sodium sensor conductivity. So based on that you can calculate. The advantage is basically you'll have to see the inlet and outlet sodium or a urea based sensor to calculate KT/V. The advantage is you need not have to have a bloodline, and the elimination of the pre-post dialysis urea nitrogen measurement can be done via the sensor, ensuring the patient that the prescribed dose is achieved, and the detection of the excess recirculation also can performing a quality assurance can be there. So it will show you how much you have achieved, and it may adjust accordingly, or you can extend the dialysis to achieve the KT/V so that the patients get at least a part of the adequacy, which is an urea based method, it can be achieved. So what to do online KT/V if it is target? It's below the target, verify the prescribed blood flow and even a dialysate flow, and evaluate is there any thrombosis or any change in the thing. So even if it is above the target, see the stepwise whether it check the other parameters. So if the KT/V is on target, monitor the documents every 15 minutes and can continue. So you need to know even online KT/V, if you are not developing, why you are not target is not achieved, you need to know it. And whether increasing the dialysis duration or the KT/V beyond 1.65, whether it is beneficial, it has not shown to be beneficial. So kidney is just multiple things. What we are doing is only urea based clearance or the nitrogenous waste products. So everything can't be matched with our kidney, which is working 24/7. So we are doing only for 12 hours, which is 1/14th of the kidney function. So KT/V is only one of the component of adequacy. So what is it? The patient's multidisciplinary assessment has to be done. So the patient's outcome will depend on the small solute clearance, residual renal function, and the LV hypertrophy, which is extracellular volume and higher weight range, and also heart variability, serum potassium, electrolytes, everything which will lead, and it will have an impact on the long-term outcome. So you need to plan the treatment duration, frequency, and whether you need to incremental dialysis and the preservation of the renal function. All these things are there for optimum dialysis. So it's, not only you have achieved a KT/V, you won't be your dialysis good, but you may have to look at all other things. So KT/V or adequate is one thing which is important, but you have anemia management, because anemia also kills people, and your quality of life suffers. Good nutrition and solid control, BMD management, fluid and BP control. This completely, when you take care of, it is an adequate dialysis. Otherwise, it is not. So NPCR is an important. If you see that, if the patient is not eating at all, you are not going to achieve anything, and yes, nutrition is an important, which I'll come to that. If your albumin is lower, less than 4, then you have an increased mortality, even though your PCR is good. So you have to have multiple parameters, you need to take it. So if you see the high as compared to low, and things in the unadjusted RR is very high, hazard ratio is significantly high, so more mortality. So the protein has to be good of around 1.2 gram per kg if you take it. This is the chart which shows C and D are doing better as compared to A and B. The mortality is higher, so the survival is poor. A means that the PCR is NPCR is less than 1.2 and the albumin is lower, and the B is PCR is high but the albumin is lower, and here D is NPCR is more than 1.2 and the albumin is more than 4. So these are the things. Then comes the PCR is less and albumin is more. So if the albumin is more than 4, you do better on dialysis. So you need to eat well, and even NPCR and albumin nutrition has to be taken into consideration. Ultrafiltration is important. As sir said, whatever you do, some patient they develop hypotension, very difficult to manage. So up to 10 ml, it is very easy. You can target up to 2.4 liters. 10 to 13, then you may have more than 13 ml target, you have an increased mortality of 1.71% increased mortality. So ultrafiltration, you do it, there is stunning of the myocardium, and if there is no hypertension also, you're going to ongoing damage to the heart is going on. So ultimately it leads to a problem. So why it is? Because your reperfusion or the refilling of the intravascular volume may be slower in these patients. So the patient dependent variations in this are pre-dialysis plasma volume and the oncotic pressure, hypoxemia, non-osmotic sodium storage, everything is, and the procedure related like ultrafiltration rate. Higher the rate, more than 12, which is hazardous, and dialysate temperature and dialysate buffer composition. You may have to keep little bit sodium high and the dialysate temperature lower so that you can get less hypotension. So less than 10 ml is better. You have less mortality, and if you go beyond 13, there is increase. So if you want to dialyze the patient, he comes with 5 kilos, better to tell them have one more dialysis session that will improve his quality and less complication as compared to achieving a dry weight with 5 kilos ultrafiltration. So more 14 ml ultrafiltration, you have unadjusted hazard ratio is 19% lower and adjusted around 43% higher complication. So mechanical studies have shown that intradialytic echo or troponin and endotoxins have which have seen that the ischemia of the heart is going on when you have a higher and higher ultrafiltration. So weight gain and the mortality, so and association with albumin. So patients who have a higher vintage and also increased dialytic weight gain, it has to be balanced. If the albumin is good, sometimes they may tolerate a little bit of more ultrafiltration, and otherwise the confounding factor are the SpQDA, calcium, phosphorus, hemoglobin, and the treatment time. It will confound it. So some patients they may tolerate, but every patient which is higher, they may not. And the fluid and electrolytes balance is important along with the KTOIV. So the sodium or the albumin, if it is more than 3.54, they have a good outcome. And those who have a bicarbonate less than 17, pre-dialysis bicarbonate, and up to 24, it's good. So if there is any less than 17 and more than 24 to 27, then they have more mortality. More mortality with higher bicarbonate pre-dialysis is because they have more and more infections, and less bicarbonate, less than 17, they have more of sarcopenia and bone problems. So you have to have at least 17 to 24 bicarbonate pre-dialysis is good. So in that case, you need to adjust it to dialysis bicarbonate of around 28 to 30 so that you can measure the pre-dialysis bicarbonate more than 17 to less than 24. So if you have potassium is also, if it is less than 4 and more than 6, you have more mortalities. So lesser the potassium, more it's also a problematic. So this is the production model which shows that the post-HD serum electrolytes disturbances in all dialysis patients. So 40% patients have hypokalemia and 67% has hypophosphatemia immediately. So the serum potassium reduces by 1.2, serum phosphorus reduces, magnesium, bicarbonate increases by 5. So a lot of electrolyte disturbances which are happening during the dialysis. So it is going to have an impact. So if you are doing a faster dialysis, the rate of change is much higher. If you do longer duration, it will be much lower. Anemia is an part and parcel, and if you are not corrected anemia, they don't tolerate the ultrafiltration, and even the cardiac problems are also higher. You all know even the uremia and the anemia both are cause LV hypertrophy and the coronary heart disease and the congestive heart failure, which increases. And those patients who have anemia, they have event-free survival is very poor as compared to those who are non-anemic. So this is also another chart which shows that all-cause mortality is very high as compared to those who are not anemia. And the erythropoietin dose is also important. In one of the guidelines, I think Lobod wrote, which is saying that those who are requiring a less erythropoietin and the UFR is less than 10%, and the less antihypertensive requirement, and the no hyperkalemia, and they have maintained no diabetes, and they live longer as compared to other patients. The requirement of erythropoietin higher and higher, which shows that they have more and more inflammation, and you have to require more and more erythropoietic dose. phosphate is important again as compared to 3.5 to 4. C really increased phosphorus, increased the mortality, and this is one of the recent paper in 2020 which showed AUC calculation above 4.5, and they have shown that those who have lesser AUC of phosphorus have a lesser mortality as compared to more than 2 have a worse, almost around 1.5 to 1.7 times more mortality. So phosphate control is important, and each dialysis almost removes around 800. So if you are doing 3 times a week, 2,400 per week, usually actually you are taking almost around 4,200. So 1,800 is left. If you calculate per day, you have to remove around 250 if the person is taking a good amount of protein, which is not possible. You can increase the duration of dialysis, extended dialysis for 5 hours. You can be able to take instead of 2,400, you can take up to 3. And nocturnal dialysis may improve, and the post dilution of hemodiafiltration you'll be able to increase up to 3.3 gram loss, and the peritoneal also will. So BP control is also a must, and if they have a BP is more than 200, you know it's a very poor as compared to 120 to 160, they are overlapping. So the relative is better. So if you have more than 140, then it is post dialysis weight should be 130/80, which is on best. So during the HD and interdialytic period, they have multiple hemodynamic stress which is happening. So during the dialysis, acute hemodynamic stress because of the fluid depletion, hypovolemia, hypotension, electrolyte changes, ischemia, arrhythmia, and thermal balance. But in a chronic hemodynamic stress happens during the interdialytic period, and hypertension, congestive additive remodeling. So everything is continuously, it's happening even the patient is on dialysis or not on dialysis. So at least you can reduce the complications by controlling the blood pressure and the volume. So if the KT/V is low, then you need to achieve the volume and check for the blood flow, vascular access, and check for the coagulation efficiency, and you may have to do it. So these are all the adequate parameters which I'll go into the detail because the time constraints. So you have to have a well-functioning, long-lasting fistula, residual renal functions, the hospitalization should be reduced, and even the complications. For that, you need to have a good functioning fistula and the dialysate and the bicarbonate buffer system, and the dose of dialysis should be around 1.2 to 1.3, which is only a part, and the surface area dialysis should be good. If you see this, those patients who have a male in the general population at 40, if the patient has an ESRD or a CKD, it's only 10-year survival as compared to 35 to 40-year survival. So we need to increase these survival of the CKD patients, because serially if you see very dismal survival, it is like a cancer patient. So even at 40, if the patient has a CKD, he is only 10-year survival, and up to 80-85, it is a similar. So with decade effect, this is in the children which have significantly shown an improvement. So improvement is there, but again, we have to improve. And if the patient is a diabetic, then it is non-diabetic and age less than 65, they are better. And those who are elderly and diabetic, they have a poor outcome. What we are checking is basically mortality, vascular access, cardiovascular. So it's based on the anemia, depression, ability to work. So all these parameters are the baseline, and so that we can take care of the mortality, access, and cardiovascular disease impact. So everything will contribute to the patient's outcome on dialysis. So we need to address as far as possible so that we can have a better things. So take home message is, fluid expected to be removed, it depends on the dry weight, and it should be less, only 10% is better. Pre-dialysis blood pressure less than 140 without antihypertension is a goal, but when you reduce the dry weight, it can happen. And the potassium should be less than that, bicarbonate around 424, and the inorganic phosphorus should be controlled, hemoglobin should be around 11 to 12, and albumin should be lower so that we can achieve it. This is one of the lady who she was on dialysis after a transplant. So she was doing a Bharatanatyam and collected around 40 lakh rupees for her fellow patients. So if the patients, it's not only dialyzing the patient and going home and sleeping, she can do a Bharatanatyam, everybody can do it. So we want the patients to do like this, be active on dialysis, not just going home and sleeping and saying the patient, I am on dialysis so I can't do work. So you need to be work